Now that we've covered the cell wall drugs, let's move on and talk about the protein synthesis inhibitors. We'll start with this figure that reminds us of some of the steps in protein synthesis. We have specific drugs, and their targets are illustrated in this picture. Let's start with tetracyclines. Tetracyclines have an ability to block the docking of the tRNA with the ribosome. So when that new tRNA enters the ribosome, if a tetracycline is present, it cannot bind effectively and continue with protein synthesis. On the other hand, macrolides block translocation. In a two-dimensional picture, it's very difficult to imagine what's going on in translocation. But basically, translocation is where the tRNA at the acceptor site moves over to the donor site. It's movement from the A site to the P site. In the presence of a macrolide, you cannot translocate, and therefore you can't continue with protein synthesis. Our third drug here, chloramphenicol, blocks the enzyme peptidyl transferase. Peptidyl transferase is the enzyme that transfers the growing peptide chain from the P site tRNA over to the A site tRNA. You have to transfer that chain in order to continue with protein synthesis. Chloramphenicol blocks that enzyme, and in essence, you're frozen at the P site with that peptide chain that cannot be transferred. These three mechanisms for protein synthesis inhibitors are the most popular test questions. This table also does a nice job of summarizing the mechanisms of our protein synthesis inhibitors. But as we look at the table, the first thing I want to cover is how to divide the protein synthesis inhibitors into 30S versus 50S drugs, because that could also be the basis of a test question. 30S drugs are aminoglycosides and tetracyclines. The 50S drugs are the macrolides and what I call the singles. Any drug that I see as an individual drug in this table, meaning it doesn't fit into one of the three groups that I just listed, I'm calling that a single. Examples would be linezolid, chloramphenicol, and clindamycin. The combination drug dalfopristin and quinupristin doesn't really have a group that it fits into, so I'm calling that a single as well. All of those individual drugs work at the 50S subunit. So among the three groups, aminoglycosides, tetracyclines, and macrolides, 2 out of the 3 are 30S drugs. Use the previous figure to go over the mechanism for tetracyclines and macrolides, and down at the bottom of this slide, you can see the mechanism for chloramphenicol. Again, those are very popular as questions. When we look at the activity and uses for aminoglycosides, we have to start with how these drugs get into the bacteria. It turns out that they are bactericidal, and they're actually unique among the protein synthesis inhibitors. They're the only group of protein synthesis inhibitors that are bactericidal. The remainder are actually bacteriostatic. In order to get into the bacteria, aminoglycosides need oxygen because they go through an oxygen-dependent uptake system. That means in low to no oxygen environments, these drugs are never going to be effective. Anaerobes are resistant. Notice that the spectrum includes gram-negative rods. Aminoglycosides kill a number of gram-negative rods. You would have to say that they're narrow in spectrum, but there are a lot of gram-negative organisms that can be killed by this group of drugs. The drugs include gentamicin, tobramycin, and amikacin, most often used in combination, as we've seen earlier, for synergy. Gentamicin, for example, can be combined with penicillins to kill Enterococcus, Pseudomonas, and even occasionally for Listeria. Streptomycin is a drug that we'll talk about later on for its use in tuberculosis. There's really nothing outstanding about the kinetics of aminoglycosides. They're polar compounds, they're very water-soluble, so they're not absorbed orally or widely distributed into tissues. They are eliminated by the kidneys, so you have to adjust their dose in renal dysfunction, which means they follow the rule that I've given you before. Watch out for the side effects of aminoglycosides. Nephrotoxicity and ototoxicity are 2 of the most classic side effects. With nephrotoxicity, it includes proteinuria, hypokalemia, and acidosis, and it's usually reversible. But you have to watch out if the patient is taking other nephrotoxic drugs. Earlier we mentioned vancomycin, but amphotericin B, the cancer drug cisplatin, and the immunosuppressant cyclosporin are all potentially nephrotoxic, and you can get at least an additive effect if combined with an aminoglycoside. With ototoxicity, you can get hair cell damage. That includes irreversible deafness or reversible vestibular dysfunction. This toxicity can be enhanced by another ototoxic drug, especially loop diuretics. If you think about these two side effects, perhaps you can look at the word aminoglycoside and put the emphasis on the letters NO. In fact, if you say aminoglycosides, emphasize the NO, which could stand for nephro and ototoxicity. But perhaps you can come up with something else that NO could stand for that's an important property of this group. How do aminoglycosides get into bacteria? That's right, they need oxygen to get in. NO can stand for need oxygen as well as nephro and ototoxicity. The third side effect, I will tell you, watch out, because even though this is more rare, it can still make for a very good test question. Aminoglycosides have a Botox-like effect to inhibit the release of acetylcholine, and as a result, you can see muscle weakness as a side effect for this group of drugs. Your notes remind you that you may see an enhanced effect of skeletal muscle relaxants in the presence of an aminoglycoside. I would tell you, watch out for the patient with myasthenia gravis. The patient with myasthenia already has weak muscles. So what is an antibiotic that might enhance their symptoms of their disease? Aminoglycosides, because by inhibiting the release of acetylcholine, you can further exacerbate their muscle weakness. In the margin is a note about once daily dosing of aminoglycosides. It turns out that the antibiotic effect of these drugs depends mainly on the peak drug level rather than the time above a certain level, and it continues even when your blood levels drop below a minimum inhibitory concentration. This is referred to as a post-antibiotic effect. Maybe another way to say that is aminoglycosides have such a significant effect on the organisms that it takes a long time to actually recover. Even after blood levels have dropped, you're continuing to see an effect of an aminoglycoside. Toxicity depends both on the blood level and the time that such levels are greater than a specific threshold. So in other words, the total dose is really the main determinant. I will tell you that clinically, timing of your doses is important. If you dose a patient for longer than 5 days on an aminoglycoside, the risk of toxicity goes up significantly. So if you're going to treat a patient with the strategy of synergy, let's say with a penicillin plus an aminoglycoside, you might use both drugs for 5 days and then discontinue the aminoglycoside to reduce the risk of toxicity, even if you still continue with the penicillin. On this slide, we're going to look at two of our notes in the margin. The first one looks at drugs that we don't want to use in pregnancy. In fact, many of our antibiotics should be avoided in pregnancy because of potential harm to the fetus, and that would include aminoglycosides, fluoroquinolones, sulfonamides, and tetracyclines. Maybe you're thinking, so what are the options that we can use in pregnancy? Penicillins and cephalosporins are very popular drugs, and assuming that they work on the bacteria that you're trying to kill, they would definitely be your choice. Certain macrolides are also useful in pregnancy because they don't harm the fetus. The other note looks at phototoxicity. Phototoxicity as a side effect is classic for tetracyclines, sulfonamides, and fluoroquinolones. You'll notice that I've modified that. Because if you want to remember which drugs are phototoxic, maybe you can use the mnemonic PHOTOS. F for fluoroquinolones, T for tetracyclines, and S for sulfonamides. Phototoxicity as a side effect is going to look like a rash, but it's going to be a rash on the exposed parts of the body. So the face, the neck, perhaps the forearms are going to be where you'll see indications of phototoxicity. Our next group of antibiotics are tetracyclines. Similar to aminoglycosides, these drugs work at the 30S ribosomal subunit. They are bacteriostatic, which is a property for most of our protein synthesis inhibitors. These drugs are broad spectrum. They kill some gram-positive organisms, and they definitely kill a number of what we call atypical bacteria. You should highlight chlamydia and mycoplasma as atypical organisms killed by tetracyclines. Let's also highlight rickettsia, borrelia, and vibrio, the organism that causes cholera. If we look at the organisms that we've highlighted, chlamydia is one of those. In fact, if you're thinking about STDs, here's another one. In fact, probably the most popular test question among all of the STDs is to ask one on chlamydia. How do you treat this organism? Either with a tetracycline or a macrolide. Azithromycin is a very popular macrolide. You can take it as a single dose for treating chlamydia. Doxycycline, on the other hand, you have to take for 7 days in order to kill this organism. And if you're thinking, wow, I would rather go with the single dose as opposed to dosing over 7 days, certainly that's true, but don't misunderstand. Both drugs are equally effective, and certainly doxycycline is less expensive. When I look at rickettsia and borrelia, I think about Rocky Mountain spotted fever and Lyme disease, diseases caused by ticks. If you'll remember the phrase, tets for ticks, tetracyclines for tick infections. So that takes care of rickettsia and borrelia. Maybe there's a modification of the borrelia question. You get a Lyme disease, but it's in a young kid. Well, you want to stay away from tetracyclines in young kids, so we go with an alternative here, and that would be amoxicillin. Otherwise, in an older kid and adult, you're looking at tetracyclines being a preferred drug. When we look at our specific tetracyclines, the drug doxycycline has been the most popular. Overall, it has a little bit better activity compared to the other tetracyclines. We have other drugs like minocycline and tigecycline. When you look at this last drug, tigecycline has been referred to sort of as a super tetracycline. It can be used in resistant cases where you have complicated skin, soft tissue, or intestinal infections. These can be caused by resistant gram-positive bacteria, like methicillin-resistant Staph aureus or vancomycin-resistant enterococcal infections, including E. faecium. That's the VREF. When we look at the kinetics for tetracyclines, the most popular test question involves metal chelation, because tetracyclines can bind divalent metals like calcium, magnesium, and iron. You also have to watch out for these drugs binding to aluminum. Perhaps you get a question on dairy products. Those can also inhibit the absorption of tetracyclines. So the binding and complexing with the metal significantly decreases the absorption and therefore the effectiveness of your tetracycline. The side effect of tooth enamel dysplasia and also of possible decreased bone growth are real problems, especially in children. The question might describe discoloration of the teeth, and certainly the reason why you want to avoid tetracyclines in young kids is effects on bone growth. These drugs are classically phototoxic, so watch out for a question on that rash on the forearms, perhaps on the back of the neck. Like most antibiotics, these drugs can cause GI upset. Now that we've covered our 30S drugs, we're going to move on and talk about 50S inhibitors, and the first drug we cover is chloramphenicol. While this drug has a broad spectrum, it's mostly considered a backup drug related to its toxicity. It can be a backup drug for salmonella, for bacteroides, or for rickettsia. Here's an interesting question about the kinetics, and specifically the metabolism of chloramphenicol. Do you remember how this drug is metabolized? We actually covered it back in general principles. Chloramphenicol is metabolized by the phase 2 reaction glucuronidation. And you remember why that's significant. It's significant because of the side effect of gray baby syndrome. The fact that this drug can accumulate in neonates relates to the fact that they have low levels of glucuronidase. Only when you cannot metabolize this drug effectively and it accumulates to such a high level do you get gray baby syndrome. But in the general population, you have to worry about dose-dependent bone marrow suppression. This is really the limiting feature of this drug in terms of why it's not used more commonly. Remember, it is just a backup drug because of this side effect. The only group of 50S drugs that we have are macrolides. These are broad-spectrum antibiotics and include the drugs erythromycin, azithromycin, and clarithromycin. These drugs are great for gram-positive organisms and are commonly used as alternatives to penicillins and cephalosporins in gram-positive infections. But they also kill atypical bacteria. And let me just remind you, this is the second time that we've referred to atypical organisms like chlamydia or mycoplasma. Earlier, we saw that tetracyclines can kill these same organisms. Tetracyclines and macrolides have a very, very similar spectrum. Macrolides are also useful for Legionella. And perhaps as you think about chlamydia or mycoplasma or Legionella, along with gram-positive organisms like Streptococcus, you might be thinking about causes of pneumonias, which we'll discuss on a later slide. Macrolides are also useful for Mycobacterium avium. Many times we abbreviate this as MAC, Mycobacterium avium complex. So remember the use of these drugs for that organism. When you look at the kinetics of macrolides, they are major inhibitors of cytochrome P450 enzymes. But back in general principles, we put them in alphabetical order, A, C, E, because azithromycin has the least P450 inhibitory effects, and erythromycin is the best P450 inhibitor. Clarithromycin, right in the middle, also has some P450 inhibitor effects, so watch out for drug interactions with clarithro or erythromycin. A property of these drugs that's really a side effect but also a clinical use is that they stimulate motilin receptors. When you stimulate motilin receptors in the GI tract, while that can cause GI distress, that can also be a clinically useful property in treating gastroparesis. Commonly, you get a vignette with a patient who has diabetic gastroparesis. Remember that diabetics get a number of neuropathies, including damage to the vagus nerve, which decreases GI motility. Drugs that are useful in this condition include erythromycin or the pro-motility drug metoclopramide. In fact, if you put many of the properties of macrolides together, you can use my mnemonic that I've got at the bottom corner of my slide here. It's kind of like if you remember macrolides, you have to say And if you put that together, the capital M is for macrolide. The next two M's could stand for organisms that are killed by macrolides. So what would you think? Mycoplasma and MAC are killed by macrolides. The other two M's can be properties of macrolides. One of them is on this slide. They stimulate motilin receptors. But what's the last M? Do you remember how you get resistance to macrolides? Resistance develops when you get methylation of the binding site. So the last two M's are for motilin and methylation, a property and a resistance mechanism for this group. Finally, macrolides can prolong the QT interval. Their risk of causing torsade by themselves is pretty low, but certainly you have to be careful in a patient who has a history of a long QT. In the margin is a bridge to microbiology, discussing community-acquired pneumonia, which I abbreviate on my slide as CAP. The most common organisms here, Mycoplasma pneumonia, the chlamydia species that causes pneumonia, and viruses. Certainly, pneumococcus is a frequent pathogen in smokers. Macrolides are great for various causes of community-acquired pneumonia. If it's gram-positive or atypical, macrolides are very good. On the other hand, my note reminds us that hospital-acquired pneumonia, HAP, is associated with a greater chance that it's caused by gram-negative bacteria. And while macrolides are great for gram-positives and atypicals, they're much less effective against gram-negatives. When it's a gram-negative cause, we like to use anti-pseudomonal penicillins, because Pseudomonas might be a causative organism here, or third-generation cephalosporins, which are great for many, many gram-negative organisms. Clindamycin is another 50S drug. A lot of people like to lump this drug together with the macrolides, and even though it's structurally different, it does have the same mechanism of action and the same resistance. So the mechanism of inhibiting translocation and resistance, methylation of the binding site, are both what this drug has in common with macrolides. Clindamycin is narrow spectrum. It kills gram-positive cocci, including community-acquired MRSA, but it's also good for anaerobes, especially for Bacteroides. Probably the most popular test question about clindamycin is the fact that it's notorious for causing a C. difficile superinfection, so a case of pseudomembranous colitis. Think about clindamycin. It's not the only drug that can cause this, of course, but it is probably the most popular among the test questions. Next, we have the drug linezolid. This is a drug that inhibits protein synthesis by inhibiting the formation of the initiation complex. In bacterial translation, it prevents the formation of the N-formyl methionine tRNA ribosome mRNA ternary complex. Try saying that fast 5 times, by the way. I don't see a great mechanism question on this drug. What we love to ask about linezolid is its specific use. This drug was developed to treat vancomycin-resistant organisms. Since we're getting vancomycin-resistant staph and vancomycin-resistant enterococcal infections, linezolid is a great choice for these vancomycin-resistant organisms. Its side effects: it can cause bone marrow suppression, in particular affecting your platelets. Around the same time that linezolid came on the market, we had the drugs quinupristin and dalfopristin. Quinupristin and dalfopristin together are referred to as streptogramins, and I think that's a term that you need to be familiar with as well. So when you say streptogramins, it refers to this 2-drug combination. They work at the 50S subunit. They prevent the interaction of the aminoacyl tRNA with the acceptor site, and they also stimulate its dissociation from the ternary complex. Basically, it's unlikely to be a mechanism question with these drugs. The question is more likely about their spectrum. Let's look at that on the next slide. When you look at the spectrum of activity for quinupristin and dalfopristin, this 2-drug combination is very similar to linezolid in that it's going to be used for vancomycin-resistant organisms. That includes vancomycin-resistant staph, VRSA, and vancomycin-resistant enterococcus, VREF, and the F is the phaceum. That's the specific species that these drugs are used for.